Did you share any link in the group? Is there any link, Zoom link in the group? Okay, I think I've shared, right?
Você tava com bigonga? Você tá com bigonga?
Okay. Good morning, everybody. It's okay. Yeah. So, good guys, let's see if we can cover this woman, the story, and go a little bit far. So, let's start with 15. Go back. Nutrition. I think we must see be able to cover the related topics, maybe 15, 16, 17 today. And then. So this topic is straightforward, and I know many of us are familiar with the concept already, so we may not spend so much time. We only look at the most important. So start with nutrients, right? In types of nutrients. So we have carbohydrates, proteins, fats, vitamins, and minerals. I think we learned about it in our secondary or in our high schools. So the question now here is, under carbohydrates, you can see the food sources, which are food, vegetables, breads, cereals, rice, pasta products, and milk. So my question is, do you get carbohydrate from vegetables? When you eat vegetable, do you eat it to get carbohydrates or to get something else? Why is vegetable included as source of carbohydrates here? Do you agree that you can get carbohydrates from vegetable? What do you think? Okay. Okay. Is it? Yes. When you add vegetable to your food, do you add it to get carbohydrates or to get something else? Minerals. So do you get carbohydrates from it? Yeah. I didn't hear.
I'm really sorry about that. We can't reach out to the other. I don't want to give you the answer. Can you give me by tomorrow? Because I'm not in Qatar right now. And the other certificate that in my old is my sister can access the certificate. I already just said.
Do you get carbohydrates from food? I'm looking at it because it looks like the children have other fruits and vegetables. That's my argument. So let me also hear from you. You see, in this list, sources of carbohydrates. They started with food. Then breads, cereals. Well, all of us know that we take carbohydrates from bread, from rice, from pasta, Why did they include fruit and vegetables? Does it mean that fruit and vegetables? I don't want to cover specific. So does vegetable give starch or mineral or vitamin? You support, right? 100%. Okay, gifts. What do you think? Do you support or disagree? You're still processing. Okay, okay. Helita is right. Hannah one. You support her. So I think you should clap for Hannah and again. Yes, they are very correct. I think this is the only class I've gotten it right. Most classes they will say, oh, it is not right. You cannot get carbohydrate from vegetables. You see, when you eat food, something like apple, all right, some fruits are sweet. The reason why they are sweet is because they contain glucose. All right, they contain fructose. And fructose is carbohydrate. All right, so that's why if you eat it, you get some glucose, even though the amount of glucose in it is very small, but it also gives some glucose. That's why if you eat fruit now, if you are tired, you may get some energy from it. All right, so someone can eat fruit and sleep. Why? Because it has some amount of carbohydrates. The research is applicable to vegetables, rest. So carbohydrate gives immediate energy. So if you eat it now, you can get immediate energy to do something, to walk, to do some other things. Then fats. You can see again, you can get fat from vegetables, vegetable fats, vegetable oil. All right. Then oil, butter, meat, milk, product, poultry, and all that. So carbohydrate and fat, both of them give energy. But the difference is that carbohydrate gives immediate energy, while fats gives reserve energy. So when you eat fat, your body will store it in your skin. All right, you can use it later. So when you're hungry, your body will then convert it back to glucose. All right, there is those of you that did what is it called? I think you did biochemistry, right? Okay, home economics. Yes, in nursing school, it was done biochemistry. All right, you see the glycolysis and all that. Okay, all right. Then the next thing here is proteins. Under protein, there are two types of protein. You have complete proteins and incomplete protein. So the question is, can you eat food, something like rice, for 1 year? Just only food without eating meat. Without eating egg, without eating chicken, without eating beef, just only food. Can you do that? Is it possible? Only rice or just only food without protein, without meat, without egg, without anything. Just only rice, food. Mhm. Mhm. No. Let's forget about vegetarians. I'm talking about you. No. How will you feel? Deborah, how do you feel? You don't eat egg, meat for 3 months. Eh? Only food without. Yes, the truth is that that's where if you look at it, you see protein is made up of amino acids. All right. So when we talk about complete proteins are the protein that has all the amino acids. Why incomplete proteins are the ones that don't have all the amino acids? So animal proteins, all right, are complete protein. Why they have all the amino acids? Why plant protein, right, are incomplete protein? They don't have all the amino acids. So if you eat only plant protein or only plant-based food, you won't get all the amino acids. That's why you need to. You need to combine those plant-based food together with animal-based food just to get complete protein. All right, so complete proteins are derived from meat, poultry, fish, meat. Plant proteins are derived from them, beans, vegetables. All right, but they contain complete proteins. All right, then vitamins, sources of vitamins, vegetables, meat, meat, and a lot of that. Okay, so balanced diet, just we are familiar with that, contain all these food classes. That's why in the hospital, when they want to serve you food, what do? They don't bring one big bowl of food for you. They bring small things, combine them together. What do they want to achieve? They want the patient to get all the classes of food. If you look at this plate here, this is the ideal plate that a patient or an individual should take, all right, to get balanced diets. Look at here. This plate has almost all the classes of food here. This is vegetable, all right, which we stand as source of minerals. Protein. This is grain, that be the source of carbohydrates. This is dairy, maybe the source of fats. All right, then fruit, source of minerals and vitamins. All right. So there's something called My Plate. It's a website that someone can use to measure the amount of food he or she can take a time, either to reduce weight or to maintain his or her weight. All right, myplate.gov. Maybe let's see if we can get it. Let's. So this, it takes into consideration your weight, your height, your age, your activity level to calculate the amount of calories that you should get per time in a day, either to reduce your weight, to add, or to maintain your weight. All right, so want to check is daily calorie need. You want to check? To go with your nurse, I need a nurse that will check her weight and her height. So we'll start with age. What is your age? 10 years, right? Pregnant, breastfeeding, neither, right? Okay, so height. Henrietta, let's height. Okay, what's our weight first? In kilogram. 7.8. That's 76. So height. Height is centimeters. Centimeters. That's cm and inch.
It's still okay, 92. Yeah, yes. Yeah.
What do we have? 150, right? Add 5 to it. Because our this scale is a little bit, it's about 5 cm below. There's a factory error. Okay, so how active are you in a day? How active are you in a day? 60 minutes? Okay. All right, so age, okay, I think you're okay. Okay. Let's be a full plan. So you need to achieve a heavy weight. You need-
I don't want to gain more.
Yes, no, this is for them to see to achieve a heavy weight. The weight is too high. Their job is done. But for them to say to achieve a heavy weight, okay, means your weight is much. So to reduce is what you need to eat. Let's go. Hmm? Okay. All right. So, where do you start from? These are fruit juice. For fruit, what you need in a day is 2 cups of fruit juice. Too much or too small for you? Are you watching your diet? 7 days fast.
Yes, I can eat that.
10 in the morning. Then 4. That is it. Okay. Okay. One water. Then your breakfast consists of what? 2 eggs. Okay, let's check. Let's check. Under protein, what do you have under protein? Okay. Okay, 1 egg. Okay, 2 eggs. How many? What? How many cups of juice?
Those three Jews. And sometimes I will toast bread.
So how many bread? How many slices do? Okay, yeah, is 1 slice bread here. 2 eggs. Okay. Okay, from here, what they have is for carbohydrate is 1 slice bread. All right. Here for egg is 1 egg. All right. Then for juice is 1 cup of 100% juice. Okay. Then for which other one again? For dairy is 1 cup of milk. Okay. I think that is okay. Eating late, eating early. That is okay. I mean, eating your breakfast late, eating your dinner early. That is okay. But the most important thing is exercise. Yeah. Yeah. Anyway, without exercise, diet alone may not be that, because if your weight is more of genetic, diet may not do much until you incorporate exercise and yeah, to burn more calories. Yeah. Is that okay? Okay, you're doing exercise, right? Wow. That's a nice one. Let's calculate some more. Let's see. Okay. Yeah. So I will check one. So I will move on. Yes, let's take for Gabriel. Let's see. 2,200 for her, right? What is that weight? It's a child. Which, right? But because of her height, no, she's a bit taller, maybe about 152. A bit taller, about 152. What's it still? Yeah, it's possible. Yeah. You need to eat more. Come and see for you. To maintain current weight, achieve a head weight. So I need to eat more. Let me check your BMI.
Let's check your network.
No problem. Yes, we are going for our wash yourself. And almost good. It's not correct. It's a little long. See, your BMI is overweight. Because of your height. So, I think maintain your weight. This is 25.6, which is just at the borderline, right? The maximum is 25. But yours is one. So if you maintain your weight, but for them, they expect you to reduce your intake a little. You see, when we'll talk about BMI, don't worry, I will do for everybody. So let me move on. We have so many things to do. Okay? And in class, I will do for yes. So what happens is you can just take your parameter, okay? I will share the website. So what you just do, just input your parameters, then check your caloric need. You see, when it comes to BMI, what do you think about it? Is he underweight or overweight or normal? Gabriel. What do you think about Gabriel? Small. Half, yeah. Yeah. So what do you think? Do you think he's underweight or normal weight? His weight is 63. Then his actual height is around 157. No. So his BMI is 25.6. All right, which is around it is at the borderline between normal weight and overweight. If you look at him, he looks underweight, right? Yes. So if you're talking about BMI, you have to take into consideration the weight of the person as well as his height. He's not tall. If he was very tall, all right, it could be a different thing altogether. As when you are very tall, just as tall as him, okay, your weight, your BMI will be okay. But because you're not very tall, all right, that's why your BMI is a bit on the high side. I think in level 5, look at BMI calculation and see how weight, height affect BMI. It's not how you look that determines your BMI. It's actually your actual weight, also your height. All right. So now caloric need. If you saw when we did calculation here, you see they said that you need so calorie in a day. For him, they said he needs so calorie to maintain his weight, or he needs to eat so calorie to achieve a healthy weight. So what is calorie? Calorie refers to the amount of energy that you get from the food that you eat. So if you eat egg, that egg has a measure of energy that it gives you, all right? And that energy it gives you is measured in calorie. You understand, right? Now, if you measure your height, what do you measure your height in? Centimeter, right? So the amount of energy you get from the food you eat per time, it is measured in calorie. So if you go to hospital now, or if you have a client at home and you are to feed the client, they measure the food. Yeah, this place is hot. I think this is not really doing good job. They measure the food they give to patients in calorie. The doctor or the dietitians will say this patient will get also 300 calories 3 times in a day. And most times they will convert it from calorie to meals. We'll still talk about that, especially those that are either on NG2 feeding or on gastrostomy feeding or PEG feeding. Talk about that in short while. All right. Then, food given to patients or diets, patient diets are divided into two. We had one called general diet and the other one called therapeutic diet. What is the general diet? The general diet is the normal diet that is given to normal patients. Let us assume a patient maybe has fever, and the patient is on admission. The patient will be given normal diets, right? The patient that has maybe urinary tract infection or something else, the patient can be given the normal diet that he or she usually take at home. So a diet that is normal, that is given to everybody, that is the general diet. It has different, you can either call it general diet, you can also call it regular diet or half diet. In the hospital, they call it regular diet. All right. Then you have therapeutic diet. Therapeutic diet has different forms. This is the diet that's given to specific patients, those that have specific problems. For instance, a patient that is hypertensive, all right, there's a modification on his or her diet. Which modification do you think they would do? You have a client at home and you measure the blood pressure of the client, and it is around 140/90. And you are the one taking care of the client. What will be the advice that you give to the people that prepare food for him or her? Yes, they need to reduce the amount of salt that they put in the client's food. All right. So what happens is that when someone goes to hospital and they measure the person's blood pressure, and the blood pressure is around 140, 145, or 150, doctors will not start the person on medication immediately. What they do is that they tell the person to go home to reduce the amount of salt that the person takes and to measure his blood pressure every day for at least 10 days. If the person reduces the amount of salt he takes, measure his blood pressure for at least 10 days, and his blood pressure is still very high, it is then that doctors will then start him or her on medication. Apart from low salt, what other things do you think you can do? Or what other adjustments can you make in the patient's diet to control his or her blood pressure? Carbohydrates for hypertension, you are talking about hypertension, high blood pressure. Your clients, the blood pressure, you measured it in the morning, and it is 145. You measure it again in the evening, it is 140. All right. What will you do before the patient is started on medication? Oil. All right. Instead of frying the person's fish, Okay, you rather boil it. So reducing the amount of fried things the person takes. Okay, and then if you have to cook chicken, what will you do in the chicken? Removing the back, skinning. By the time you skin it, you see you have removed some fats or some cholesterol. Most high blood pressures are caused by high cholesterol level, right? And by the time you reduce the amount of cholesterol in the person's diet, it can also help to bring down the blood pressure. So just as you said, removing the sugar, the salts. If you put Maggi, you have to reduce again the amount of Maggi. Either you reduce or you remove. You stop frying, all right? You skin the chicken, and then the person has to start exercise. Right? By the time the person do these things for about 1 week or 2 weeks, and the blood pressure is still high, that person definitely has hypertension, and doctors will definitely start him on medication. All right, the next thing here now is, if you have a client that is diabetic, what will you do? Your client is diabetic. What advice will you give? Please, those online, can you hear me clearly? I think with my face mask, my voice will not be very clear.
Sir.
You can hear me clearly, right?
Yes, sir.
Okay, okay. So you have a diabetic client. What will you do in the diet? Sugar. How? You want to make it practical. With sugar. Okay. You see me? You see me? I can't remember the last time I ate sugar. We're talking about the person's regular diet. What will you do in the normal the diet of the person? Okay, so start. Just go on. Okay, let her finish. Then you can make your suggestion. Okay. Okay, how?
Yes.
Okay. So let's assume now. Let's assume the person's normal diet is this. In the morning, the person eats something like tea and bread. That is the person's regular diet. In the afternoon, the person eats rice. That is the person's regular diet before the person was diagnosed of diabetes. Do you understand what I mean?
Yeah.
Then at night, the person's usual diet used to be something like the same rice, but cooked in a different form. Jollof rice. So now you are the caregiver. What will you do? Sorry? The question is for everybody, but you attend first, the other persons will also attend. You see, it looks, all the things looks abstract to you, or it looks as if like something that will not happen until you start looking for a job. When you start looking for a job, you assign a client and you don't know what to do with the client. Let me tell you, today, one of the students got a job to take care of a baby and a 10-year-old boy with cerebral palsy. I think we talked about cerebral palsy before. A 10-year-old boy with cerebral palsy, and that boy has tracheostomy. I think we talked about tracheostomy. The same boy again has PEG tube. We'll talk about PEG tube today. So the client was being taken care of by a nurse, but the nurse wants to stop. Now they want to hire a nurse assistant to take care of the child. And the nurse assistant went. So they told her the starting salary was 2,300, and she was to start duty today. 3,003. 3,003. Money, right? And she was to start duty today. The plan was for her to start duty. The nurse that was there will take her through, put her through, teach her how to do the suctioning, how to feed patients on PEG tube, and also how to do the management and other things. But she was afraid. Yes, she was afraid. She was afraid. So there is nothing we do not do to convince her. Sorry, she declined the job. Yeah, she declined the job. She didn't take it. She declined the job. But what happened is that she already has, this is her third offer. Third offer. She already has one job already. And that job is 4K. 4K. Then this one, she just went for the interview today and got this one. So she felt that maybe this one is more complex than the other job. So that's why she declined this one. But for me, the job is good actually. This job is good, but I know she'll be stressed. But the patient has cerebral palsy. She has tracheostomy in which, and she also has PEG tube. Sorry? He's paying well. So she insisted that this guy should pay her 4K. But they said that they cannot pay her 4K, that what they can pay is 2,003 with transportation. Yes, first one is also home care. So you have to choose the first one. But I think the reason why she declined this one is not because of it's because of the complexity. Yeah. So sometimes some things that looks simple, that looks like you may not have such clients. I know to her, she never thought she would get a client that is as complex as this. When she was in class here, I remember when we were talking about how to pass NG2, how to check it, how to feed and all that. So I was like, oh, this is not possible. She cannot do this. Then when we were talking about tracheostomy, I remember the student very well. If you project tracheostomy, how to search up tracheostomy, she would just close her eyes. So I just knew she declined the job, not because the money was small. No, I think the nurse has completed her contract, but she wants to, the agency wants to mobilize her to someone else. But that's a good question, actually. That's a good question. Okay, so now you have a client that's diabetic. What will you do? This is the client's regular diet. How will you adjust or make adjustments? Brown bread. Okay. How about rice? Okay, next person should that attention. Okay. Carbohydrates. Yes. Yes, you're on the right track. Yes. Then in the afternoon, the rice. Sorry? Salad again in the afternoon. You want to use salad to kill your patient. Okay. Rice. Okay. Gabriel, what do you think? Good. She has said something good about breakfast. The patient afternoon. Ah, which one is it actually? Honey. Okay. Rita, what will you do so that we move on? The afternoon, yes, yes, yes.
Here we can.
I think this your class is too intelligent, right? Yes. Yeah, you guys are doing very well. Yes. You see, the right thing to do is portion control. You may not really change the patient's diet entirely. You can reduce what the person plays per time. Right? For instance, if you want to give the person rice, you can use just estimate with the feast of the person. The rice should not be more than the feast. All right, your measure. Sometimes in the hospital they tell them use each so number of spoons, right? But that may not be very feasible. You cannot start counting spoon. Just use the feast to measure the amount. Then you then compensate other things, vegetables, some fruits, all right, and other things. More of like, for instance, if you are putting cooking rice, just make a small rice, more salad, more stew or something, and proteins to supplement. If you want to cook wheat, you want the person to eat swallow, what will you do? Just something like this, right? Then the soup has to be very big just to compensate. Yeah, by doing that, you are reducing the amount of sugar that the person gets per time. Most times, again, the hospital dietitians will advise them the portion should get per time. So this is a form of therapeutic diet. Why? Because you have removed something or you have reduced the amount of something in the food just because of the patient's condition. Another form of therapeutic diet is patient that had surgery. When a patient has surgery, what do? The patient doesn't start solid diet immediately. All right? The person has to be on it per aura for the first few hours. Then doctors will have to check the patient's what is it called again? First of all, the way they come in the morning, they ask the patient, have you passed flat tooth? Or have you opened borrow? Have you gone to toilet? Why do they ask that question? You know, sometimes when doctor come into the room of a patient and has surgery, they will ask them, have you passed flat tooth? Have you passed gas? Or have you defecated? And sometimes patient is worried. Why? I don't think they ask the question. Are walking. They were not walking before. No, you have an idea. We just do. Yes, yes. Yes. Mm. Mhm. Mm. Why? Mm, 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 Okay, the gas that they put inside. No. No. That is the only time they put gas inside is when they are doing laparoscopic surgery. They want to put gas just to inflate the abdomen so that they will be able to see what they are doing. But for normal surgery, they don't put gas. The reason why they do that is, you see, during surgery, if they use general anesthesia, what does the general anesthesia do? It will relax. First of all, it will make the person unconscious. Second thing the general anesthesia will do, that it will relax all the muscles in the patient's body, including the muscles of the intestine. So immediately after surgery, the patient's intestinal muscles are relaxed. So if you tell the person to eat food when the muscles are relaxed, if the muscles are relaxed, those muscles are not active. They cannot push out food. So if the person eats food, that food will just stay in the stomach. It cannot go down to the rectum. So they have to wait for the intestine to become active again before the person starts eating. That's why when they come in the morning, they ask the person, have you passed gas? If the person has passed gas, it means the intestine has become active. If the person has opened bowel, has gone to toilet, it means the intestine is already active. If the person has not passed gas, I want to open bowel, they will use stethoscope and place it in the abdomen to check if the intestine is moving. Now, if I place a stethoscope in your intestine, I can hear your bowel movement. As your intestine is moving, it makes sounds. All right? So when they listen, if they hear the sound that comes from the intestine, it shows that, look, the intestine is back. So that's why they come in the morning, they'll check. If the bowel sound is back, the first thing they'll do is they tell the person to take water. And after taking water, after some hours, they tell the person to take fluid, clear fluid. After taking clear fluid, next one is what? Liquid diet. After liquid diet, before the person start taking solid diet. And so those liquid diets, right, is also a form of therapeutic diet. You see in the hospital, most times when they get food for patient, if you look under the meal card of the patient, they normally write the type of diet it is. It is regular, then they write regular. In therapeutic, they write therapeutic, just showing the type of diet the patient is on. All right, I think that is basically what you need to know about it. Then looking at here, signs of poor nutrition. What are the signs of poor nutrition? One is what? Weight changes. All right. I want to talk about osteoporosis. So that those of you that will go into home care, you should be familiar with this osteoporosis. I've talked about it regularly, right? What is osteoporosis? Yes, fragile bone, which is quite common among Qatari women here. That's why in their medications, if you see every Qatari woman's medical record, you must see vitamin D, and it is taken once every month. All right, so that you not go ahead and give it 2 times in a month or every day. You're just taking once every month. The reason why they give it is they have not broken their bone yet. They just want to give it to them to strengthen their bone and to prevent osteoporosis, which is common among them. Okay, I think that's basically what you need to know. The next thing we look at here is alternative feeding methods. What are the alternative feeding methods? This for patients that cannot eat food with their mouth, all right, they can fed with tubes or with feeding tubes. All right, and there are different types of feeding tubes. The first one is NG tube or nasogastric tube. The tube is connected past from the nose down to the stomach. That's why the name is what? Naso. Naso is what? Nose. Gastric is where? Stomach. They have the other one called gastrostomy tube. The tube is connected directly into the patient's stomach. It has another name, PEG. All right. Let me see. I think if my phone is still on here. And look at the message the person they sent to the person. You can handle this case. The patient is a 10-year-old and with cerebral palsy with PEG tube. PEG tube. So when you hear PEG tube means gastrostomy tube. All right. PEG is percutaneous gastrostomy. When we talk about it, so I will see a diagram and see why the name is PEG. So how do you pass NG tube? How do you feed a patient that's on NG tube? I think you should be familiar with NG tube. Anna? Am I familiar with NG tube? So if you have a patient now, a client at home, that's on NG tube, can we feed the person? And what will you do? Or how do you feed the person? Have you seen NG tube? Someone has NG tube. Anna, have you seen the patient on NG tube? So that the patient through the nose. Have you seen? Gifts, have you seen? Patient they feed through the nose. Okay. For instance, if someone is unconscious and the person cannot eat by himself, an alternative is to put a tube through the nose. All right. Nurses would then blend the person's food. They'll change the food to a liquid form and then pour the food through the tube. All food. Person cannot chew. This is unconscious. So they'll blend all the food the person will eat, pour it through the tube, and that food will go into the stomach directly. How the person is food? No, they calculate it. They calculate it. Yes. Yes, there is a feeding syringe. Don't worry, we'll still talk about how to feed to feeding patients. See if I put something. Okay, this one is better. Okay, this is not very clear. All right, this is the feeding, the syringe you're talking about, right? Then this is the NG tube itself. So the question now is, so look at two things: how to pass NG tube. Second thing is how to check if the NG tube is in place. Because let us say you want to feed a patient and the NG tube is already in place. You don't just start feeding. You need to be sure that that NG tube is in the right place. There are two possibilities. You see, if you open your mouth, there are two openings. The first opening in the front, the opening at the back. The one in the front leads into your lungs, right? While the ones at the back leads to where? To stomach. So if you put two through the nose, that tube can take any direction. It can either enter the person's airway and block the person's airway, or it can enter the person's esophagus and be in the right place. And now, if you want to feed a patient now, why you may not know. When they placed the tube initially, that tube was in the right place. So because the patient was struggling, the tube got dislodged and was in the airway. Now you want to feed the patient, you just push food directly, and that food the food will enter the person's airway. And when it enters the airway of the patient, most times patients don't survive it. So you need to first of all check this tube that I want to use. Is it in the airway or is it in the patient's esophagus? So how do you check? That's the first thing we'll look at. The second thing we'll look at is how do you pass it? Let us know it gets dislodged. There's no nurse, there's no doctor, the patient has been hungry, you want to put it back. How do you pass NG2? All right? Okay. So let's look at, let's see if you can see. I think I was supposed to get an NG2 feeding tube here for us to. Let me get one. Okay, because I'm trying to get it. So if you want to feed a patient an NG2, what will you do? Or how will you go about it? Who wants to attempt first? So I'm trying to get that image. Okay. Sorry, this is not NG2, right? It looks like I'll use it to demonstrate. Okay. So now, if you see an NG2, it has two ends. This is one of the ends. This is the second end. Then, if you look at it, it is calibrated. It has calibration, and the calibration starts from the end that enters the node. They may start calibrating from here. Maybe they start 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, up to 30 or something. Okay? This is calibrated. That means you have to measure the length that will be inside the patient before you pass it. You need to first of all measure and estimate the length that should be inside the patient. How do you measure the length? You measure the length by first of all getting the tube, placing the tip, the one that will go inside. Place it at the tip of the nose. All right? Take it to this place, the triangle of here. Pass it through here. Then take it down to where this place. This is where stomach is. Know where your stomach is, your rib cage, this place. So you start from here, start from tip of your nose, or patient nose, not your nose, the patient. Here, tragus down to this place. Then when you get to here, you mark that point. You note the calibration that is there. If you're not sure, you can use something to mark it. You can use a marker or use a pen to mark it. What it means is that if you want to pass this NG2, you have to reach this point. If you don't reach this point, you cannot be sure that the tube is in the stomach. If you pass this point, the tube may go beyond the patient's stomach and reach somewhere like maybe duodenum which is not what you want to achieve. So this is the measurement that will give you an estimate. So when you want to push, as you're passing it through, once you reach here, you will stop. All right. Then the next thing to do now is, what are the things you need when you want to pass NG2? What do you need? You need a lubricant. All right. See, NG2 is not very comfortable, especially when the person is conscious. The person is conscious, as you try to push it in, the person may not accept it. The person may struggle with you and may not even want to pass it. It is easier to pass in a conscious patient, those that are not around. Even in a conscious patient, you need to put a lubricant, something that looks like Vaseline. Most times you use KY gel or use xenophane gel. All right. So what you do, first of all, apply a lubricant here, maybe up to here. All right. Lubricate this place very well. Xenophane gel is the best. It has anesthesia in it. By the time you lubricate it, if you are passing it, it will anesthetize the nose. The person may not feel pain. Just imagine putting something into your nose. It is not comfortable. The next thing again to do is you need stethoscope. Another thing again you need a cup. Not just a cup, but a transparent cup. And then fill the cup with water. You should be able to see the base of the cup. All right. Then you need a plaster to anchor or to secure the NG2. What you do is, before you start, you must have talked to the patient. Even though the patient is unconscious, you must have talked to him. Not to say a conscious patient, even though they cannot talk, they cannot see, they can still hear they can still hear you. If you talk to them, the reason why you need to talk to them, because by the time you pass this through, when it gets to their mouth, all right, if those of them that still have gag reflex, they will use their tongue or their teeth to hold it. And they can use their tongue to manipulate this NG2 and hold it in their mouth. As they're pushing it, it may not go in. So first of all, talk to them. Look, when this thing gets to your mouth, swallow it. Then you need an assistant, somebody that will help, that will assist you. The first thing to do is to reposition their head. If the patient is lying this way, which position do you think is best when you want to pass NG2? Do you think the head should be this way, or this way, or this way? We want to pass the NG2, right? How do you think the head of the patient should be? Should it be like this, or this? Please, those online, are you following?
Yes, sir.
Okay. So what do you guys think?
I think tilted behind. Tilted behind. The first move you did with to expose the throat, right?
Okay.
Going to
Is that winning, right?
No, Sabrina.
Okay, Sabrina. So what does it? I didn't hear you again. You said that the head should be back or forward.
The back.
It should be this way, right?
Not so back, but back.
This way, right?
Yes.
Okay. So from Sabrina's opinion, she thinks we want to pass it, we should keep the patient head. Okay. What do you think? Is correct. Rita, should go back to where should go back? Neutral position. Flora. Look at flora position again. Yeah. Oh, what you wanted to say something. There's a position you wanted to say, Bet, you must bend. That is not correct. Remember, there are okay, the one behind, the one in the front. When you do like this, so that don't take the open. Is it the one in the front or the one at the back? The one in the front. That's why we check. It's Dockers, yeah. You see, in theater, when they want to connect a patient to ventilator, and they want to pass endotracheal to the tube that enters the windpipe, what do? They bend the neck back. The reason why they bend the neck back is that when you bend someone's neck back, it will open this windpipe. Then the back one will remain closed to an extent. So when you want to pass an NG tube, and you do like this, and then start pushing the tube inside, that tube will enter the patient's airway, and you can kill the patient. So this is not the best position. What do? You bend the neck forward. If you bend your neck forward, what do you think will happen? It will block this one, and the one at the back will open. You will not bend it too much. You just want to bend it a little forward. You then use any of the nose, either left or right. You can say that left is better. You can use left. Most times, if I want to pass, by the time you push to the right, you see that it may not go in. You have to change and change the left. You see that one is more pattern. So you push, and you have to be very gentle. You push when you think it is in the mouth, then you just swallow it. Swallow it. And then you keep pushing, keep pushing, keep pushing, keep pushing until you get to the place where you marked. By the time you get to the place where you marked, you are now sure that this tube is in the stomach. But you cannot be very sure. You still need to test and check. How do you test? You have to get the cup that has clear water. All right? You dip the tip inside the cup and then look at the base. If this tube is in the airway, it is in the windpipe, you will see bubbles. You start seeing bubbles, the base. Bubbles start coming up. You have to wait and look at it for some time. When bubbles start coming up, it means your tube is not in the right place. You have to remove it. But if you wait, so most times when the tube is in the stomach, more bubbles may come out, but to stop. You have to wait, no more bubbles. You cannot also conclude. The next thing you do is you get your stethoscope. Before you get a stethoscope, get a syringe. All right? Maybe 10 minutes stretch. Draw the syringe and connect it. If this tube is in the patient airway, if you try to push it, there will be resistance. You can't push it in. There will be some pressure inside. This is because you see your lung is airtight. God is airtight. If you try to push it, it cannot enter. But if this is in the stomach, there's an opening in the anus, right? Because of that opening in the anus, when you push it, it will just go freely. So if the syringe goes freely as you push it, you remove it again, bring out the plunger, connect it back, push again. It is very free. It means this is in the stomach. You can still do the last test. What's the last test? It's your stethoscope. Put on your stethoscope, place the stethoscope at the stomach here. Do the same thing. Bring the same syringe again. Pull out the plunger, connect. Somebody can help you hold the stethoscope in your ear. If you do like this, not just slowly, do like this, connect. If it is here, you hear some crackles. You hear, come back again, check again. If you hear crackles when the stethoscope is on the stomach, it means this tube is in the right place. And when you do this, check again, and you don't hear the sound, it means you're not in the right place. So you do this test, not just after passing NG2. When you want to feed a patient that is on NG2, before you feed, you must check and test to be sure that it's still there. All right? By getting a cup, place it inside a cup of water, take it for bubbles, getting a syringe, pushing it to see if it's free. All right? And sometimes they use the stethoscope to confirm its position. Then, most times you have different ways they secure it. All right? And most times, if you're securing, you have to use a plaster or an adhesive to secure it up here. There are different designs, and the way it is anchored depends on. Most times, the patient already has it. It's already passed in the hospital. Then, when you want to feed such a patient, there's an NG tube already. Other precautions you must take is you must raise the head of the patient bed. Don't feed the patient when the patient is lying flat on bed. If you feed the patient when the patient is lying flat on bed, the food can return back to the mouth, and that can block the airway, and that can cause a serious problem. Then again, the amount of food you feed the patient per time. Most times, there will be an instruction on what to give the patient by dietitians. Sometimes they'll tell you the liquid diet you want to give the patient, the total liquid or the total food the patient should get in a day should be around 1,500 meals. That 1,500 meals will be divided into 3. That means in the morning, the patient will get 500 meals. Afternoon, 500 meals. Night, 500 meals. And that 500 meals, they will tell again 300 meals out of it will be food. The remaining 200 meals will be water. All right, so what it means is when you finish feeding with 300 meals, you then give water. All right, that water is what we use to rinse. Don't just give food and leave it. You must use water to rinse it. And that water should be part of the calculation that has been made already. But if you give more than that, you overfeed the patient. And when you leave the patient, that food can come back to the mouth. And actually, again, after feeding, leave the head of the patient inclined for some time, either about 30 minutes or about 1 hour before you take it down, so that to allow the food to digest. If you bring the person's head back immediately, it can cause a serious problem. Then, this is gastrostomy or PEC. Yes, ask your question. Yes. Which of them? Is that gastric tube? No, it is, once you use it once, yes, you cannot use it to use it. Once you finish using it and remove it, it is over. You don't use it 2 times. So this is PEG tube. Right? So this is PEG tube. You see, this tube is connected directly to the patient's stomach. Okay? All right. Then the question now is, why will a child with cerebral palsy be on PEG tube? Remember what I said, the client, he has cerebral palsy, and in addition to having cerebral palsy, he has this tube on the stomach. This is how he eats. And he has tracheostomy. So my question now is, why will someone with cerebral palsy be on PEG tube, be on this type of feeding? Why can't the person eat normally? Are we tired? She's taking time. That means she's tired. Okay, yes. You see cerebral palsy, when we talk about cerebral palsy, right, what we say then is that they cannot control their muscles. Not just the muscles in the hand, but the muscles around the throat. So they cannot control food in the mouth. Because of that, they cannot eat, especially if it's severe cerebral palsy. So this child cannot, you see, sometimes the neck will twisting to one side. So that person, if you try to feed him from here, that food will choke you. The alternative is to put this type of tube. So this is that called gastrostomy tube, or you call it what? PEG tube. PEG. PEG. No, what is type of PEG? Percutaneous button is E. They have percutaneous endoscopic gastrostomy. All right. I have to give you guys face masks, those of you that are in the front. So I will not give you. Yes, I have to, because in the last week, I have attended to not more less than 200 patients with cough. Sorry? Yes, there's an outbreak. Primacy. Yeah, it's the weather change. Can you help take face mask from you? Those masks, yes. It's inside here. It's not just cough. I remember most of them, they come with fever of about 38. Yes. So open the down one. Oh, okay. Oh, sorry. It's in the locker. Yes. So I thought I was very face mask, not really cleaning my husband's laser. But my driver also has it. So I thought I was done. Got my face mask, entered this thing, vehicle. It coughs all the way from the place to my house. The following morning, he also coughed from house.
Oh,
That was when I knew that I cannot escape from it. No. They don't. No. They don't cough. No face mask. They just cough. Not everywhere. Okay. All right. So PEG, percutaneous. So that when you are asked to take control, you will not be asking, PEG. Percutaneous. Percutaneous means they pass it through skin. Skin is cutaneous. Endoscopy. They use the endoscopy. They will not do surgery. All right. Gastrostomy. Gastrostomy. It's connected directly into the stomach. Okay. Okay. So there's another type of alternative feeding method, which is giving what is called what's his name again? Giving food into the patient's blood, not intravenous infusion. TPN, total parenteral nutrition. It's called TPN. You see, let's assume that someone had something like problem in the intestine. You see, if your intestine is okay, just that the only problem is that you're unconscious. What will they put tube here, right? Now, let us say you have problem here, and your intestine is still okay. What will they do? They put peg tube here. Let us say that your intestine has problem, and you cannot eat for months or for weeks. What would they do? You still need to survive. So instead of putting food into your intestine, they rather give the food into the patient's blood. All right? But this time it is not normal food. It's a specially prepared food called total parenteral nutrition. So it's not just like a normal drip. It is a food that looks like drip that is given into the blood. The problem with it is that most times, if the person that gives it is not very careful, it is concentrated. It can burn the vein. All right? Sometimes infection can enter the same person's body through it. Okay, so that is also an alternative method of feeding patients. Okay, I think almost through with this chapter. Then in level 5, we'll discuss the input and output charting and monitoring. All right. But the minimum thing we'll look at is what's the amount of fluid someone should take in a day. I think we talked about it. The amount of fluid you should take in a day, or the amount of water you should take in a day. 8 glasses. Okay. For me, I don't use glass. I don't think I've even seen that glass. That's what they call it, glasses. What is the size of the glass? That's my problem. So gifts, what's the amount of water I should take in a day? Okay. So how do you measure the water you take in a day? Or what amount of water do you take in a day? Sorry, yeah, you, yes. I'm talking about now, this weather now, the correct weather. 2 liters, right? Okay. 2 liters, Gabriel. A liter, 3 liters. How many liters? He said 2. She said 3. You, how many? She said 2. Hannah, how many? For the whole day. 24 hours. You see, you need to know this because when you take care of an elderly person, most of them they don't like water. They don't like to drink water. All right, so you need to know the amount of water they should get in a day. If not, they will become dehydrated. Sorry? Yes, we will look at elderly patients and see their peculiarities. see why sometimes they may not want to drink water, they don't even want to eat food. So you need to measure and record it in the chart. And then when you feel record, you have to check the amount they have gotten compared to the urine out, see if they have gotten enough. If you don't know the amount you expect them to get in a day, you won't be able to encourage them to get adequate amount. So 2, 3, 2, 3. Okay. Online students, what's the amount of water that one should take in a day?
Two liters.
How many? Sorry.
2.
2. Okay, I'm gonna say 2. Winnie, how many? Winnie, how many?
2 liters.
2. Okay.
2 liters.
Two are carried the vote, right? Majority are carried the vote. So 2 liters. You go for 2 liters now. There's only 2 persons that say 3 liters here. Yes.
I think 3 liters.
Okay, yes. Yes. But
3
also
to 4.
3. That is the minimum you should get. 3 liters is how many bottle water? Big bottle water, just 2. Just 2 big bottle water is 3 liters. Right? And I do you should even get more than that. In a day, for me, I think in a day I take not less than 3. Which is most times you can even take up to that. There's a way they can it is gotten why you expected to take 3 liters. You see, in a day, you urinate, and the amount of urine you make in a day is 4 hours and 500 minutes. For about 24 hours, if you keep urinating from morning to the following morning, all right, the amount of urine that have left your body is 1,500. So you have lost some water already for your body, and you need to replace it. You want to remain healthy. 2 again, you sweat. All right, you lose water from your skin, through your skin, from your skin. As I'm talking, I'm also losing water. All right, from my mouth. So if you calculate the amount of water I lose from my skin, and also the one I lose from my mouth, it is estimated that in over 24 hours, you have lost water. This is called insensitive loss. You cannot measure it, and you lose it. So in 24 hours, you must replace it. So now, you defecate, right? If you defecate over 24 hours, you have lost through your physics. So if you calculate it, how much have you lost in a day? This is 3,000. From that, 3,200. So in 24 hours, you have lost about 3,200 minutes of water from your body. Sorry? That's why if you have diarrhea, you lose more and you become dehydrated immediately. All right? Then your body also, when you eat food, your body will use the food you eat to generate water. So your body produces, you lose water and your body generates water from food, not from water you drink. And that food you eat generates about 200. So if you lose 3,200 and your body generates 200, what is the net loss? 3,000. So you just found what's the loss in your body to power. So you must take at least 3 liters in 24 hours in order to balance the loss. That is why in the hospital, if a patient is on admission, this is what they use to calculate the amount of drip the patient should get. They expect that over 24 hours, the patient has lost about 3 liters of fluid. So if they are giving the person drip, that drip must replace this loss. So they will then say, okay, in 24 hours, this patient should get nothing less than 20 liters of drip. How will the person get the 2 liters of drip? They will say 1 liter, 8 hours. That means 1 liter. If you hang 1 liter, it should be on the person for 8 hours. After that 8 hours, when the 1 liter finishes, when this one finishes, so in 24 hours, the person must have got to how many drips? 1, 2, 3. That's if they're using 1 liter drip. If they're using 500 ml, how many would the person get? 6. Because 500 ml will be for 4 hours. Another 500 ml is 4 hours. You keep giving every 4 hours, so that it is 4 hours. But I replace the loss, which is 3 liters. And that's how they do the calculation. But the person can get more. Yes, I'm coming. The person will get out. Yes, I'll come. If the person has diarrhea and the person is stooling every time, they will increase it. All right. If the person has stool and the person is losing blood, losing fluid from the body, they will add to it and give more than that. Okay, question. Yes. Ask all your questions. Yes, okay. That's the first question. Ask the second question, so I will answer it too. Okay. One, I think let me start from this last one. What is considered excess depends on the patient. For instance, even though what if someone should get in 2 hours of 3 liters, but there are considerations. If someone has kidney failure or a patient has heart failure, that patient should not get up to these 3 liters. All right? But if you give these 3 liters, which is for a normal person, this 3 liters will be excess, and that will cause problem. For those that have kidney failure, that have heart failure, they restrict their fluid. So in that case, we have such a patient in the house, they measure the amount of water the person should get. They'll tell you, don't give this person something more than 2 liters. So when you give any time, you have to measure it so that it will not be more than 2 liters. They measure it based on the weight of the patient and also the severity of the person's either kidney failure or heart failure. All right, that's what they will decide how to restrict the fluid the patient gets. So you just using to answer the question you asked. Giving these 2 liters to such a patient is excess. All right. Sometimes they may say, okay, don't give more than 1 liter. That depends on the fluid accumulation that the patient already has in the body. If the patient has excess fluid that has accumulated in the body, they may reduce it even to 500 ml. I tell you, in a 24 hour, don't give up to more than 500 ml. Because if you give more than that 500 ml, it is already excess. Is that clear? All right. Then what can also be excess for a normal patient is, you see in our body has something that helps to check. When you have taken excess water, there's a part of the brain that helps to detect, to measure the what's the osmolality. I don't know how to teach the amount of water that is already in your blood. If your blood is already over diluted with water, your brain will detect it and you lose taste immediately. How will I put it now? If you keep drinking water, there's part of your brain that will detect how dilute or how concentrated your blood is based on the amount of water you have taken. All right. So, and also what also is considered excess again, it also depends on the weather. Now, when the weather is let us, the weather is hot, all right? If you take up to 4 liters, it's not, your brain will not see it as, will not be too, that 4 liters will not be excess, all right? Because as you're drinking the water, you are losing the same water on your skin, all right? And that 4 liters will not be excess. But let us assume the weather is cold, all right? You are drinking water. When you pass these 3 liters, get out to 4 liters, okay? You are not losing that water from your skin. That water you drink will remain in your blood. And it will also dilute your blood, and your brain will detect the osmolality. And at that time, even you that are drinking the water will lose taste. You may not even want to drink more than that. All right? But the benchmark is that you should not get less than 3 liters. By the time you get more than 3 liters, up to 4 liters, your system will shut down. You will not want to take more than that particular amount. I think that is the easier way to put it and explain and give answer to your question. Okay? Yes. So there's something called some persons when you take there's something called psychogenic polydipsia. Psychogenic polydipsia are some people that may have mental problem. That mental problem will make them to just to keep drinking water. By the time they keep drinking water, and water is excess, it will dilute their blood to the point that their blood osmolality will be less than 250. By the time it gets to less than 250, all right, it has so many side effects or so many symptoms. Some symptoms might be the person will feel confused, all right, and sometimes it also reflects in the urine of the patient, all right, and also confusion, which other thing again, unconsciousness. Those are one of the symptoms of psychogenic polydipsia. So if someone takes excess water, it has side effects, but it has to be when the person are taking so much of it. All right. Therefore, a normal person with intact hypothalamus is able to detect how dilute person's blood is or how concentrated it is. The person cannot go beyond a particular benchmark. Is it clear? Okay, I think we will stop the chapter at this point and move to the next chapter. Do you want to go on break or do we continue? Okay, I think we may not stop by 9:30 today. May stop maybe 9:15 or so. So because of that, I'll start chapter 16. So chapter 16 talking about elimination. I think this chapter 16 will just look at the practical aspects, the things that are more important. All right. So what is the normal elimination frequency? Okay, all right. So when we are looking at elimination, we are looking at feces, defecation, and urination. All right. And Everybody has their regular elimination habit. Number of times they urinate in a day, or number of times they defecate in a day. All right, and it differs. Some person defecates once in a day, some 2 times in a day, some once in 2 days, once in 2 days. I think once in 2 days is the maximum. Some persons um, more than twice in a day, depends on the individual. All right. So some people urinate every 2 to 3 hours, whereas others may only go only once every 8 to 12 hours. That is 2 to 3 times in a day. Then when it comes to defecation, some people may just once in a day. Some people once every 2, some people once every 3 days. All right. So for you to say that someone has constipation or diarrhea, the first thing to do is to check the person's elimination habits. How often the person usually defecates? How often the person usually urinates? Before you can. So let's look at urination first. Some person can urinate more often, and that depends that the person has. If the person has prostate enlargement, sometimes they can urinate many times, like every 30 minutes. If the person has diabetes, they can also urinate very often. So it is now for you to differentiate between that frequent urination, the cause of the frequent urination, whether it is caused by diabetes or it's caused by prostate enlargement. All right. So let's assume you have somebody here, and the person every 10 minutes, the person goes to restroom, or every 20 minutes, or every 1 hour, the person goes to restroom. Or you have a client that urinates every time the person urinates. How do you know that that frequent urination is not caused, that the frequent urination is caused by prostate and not diabetes? Or how do you know that it's caused by diabetes and not by prostate? What is it about the urine that tells you that, look, this patient is urinating often, but this is what is likely causing it? Foams, okay? Okay. Okay. What else? Okay. Okay. What else? So Henrietta, you want to continue? But what is it that tells you, look, this frequent urination is diabetes, that this is not prostate? Okay, gifts. The color, okay. 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 All right. I think we said this when we discussed chapter 8. All right. You are very correct. One, if the person has diabetes, one of the things you notice in the urine that urine will smell. You may have some odor, right? When the person is passing urine, you receive we smell of the urine. But it may not be everyone. some person can have diabetes when they urinate may not receive any odor from the urine. So, but it's one of the signs. So again, just as you see, the urine foams. All right. So one of the things again is that they pass large volume of urine per time. All right, they urinate a lot. The volume of urine they urinate per time is large. But if it is prostate enlargement, what is about them is that they urinate often. But each time they urinate, they pass out small volume of urine, just small urine comes out. All right, because there's an obstruction, that obstruction will not allow urine to pass freely. So just small will come out, then the other will remain inside. They'll come back, will stay. After some time again, they feel press. They want to go back again, pass out small urine, come back again. Another thing again is that when they are urinating, they strain, all right? They have to push for urine to come out, and that comes with pain. And so that's one of the signs again that, look, this frequent urination is due to prostate enlargement, or maybe this patient has stricture or something, there's an obstruction in the urinary tract, and it is not diabetes. But still diabetes, large volume of urine per time, foams, all right, and may have a characteristic odor together with other symptoms of diabetes. All right. Then constipation is, when you say that someone has constipation, to pass through for how many days? Five to 7 days. Okay. When do you say that someone has constipation? Okay, gifts. When do you say that someone has constipation? Look at. So, what do you mean by the routine changing? How? How does the routine change? Yes, the first thing to do is to change the person's bowel habit before you say that someone has constipation, right? First thing to ask the person is, how often do you go to toilet? The person goes to toilet once every 3 days, and the person has done admission first day, second day, the person has not opened bowel. I don't say the person has constipation. The first thing is to establish the person's bowel habits, and also look at the consistency of the stool. All right. When you have established the bowel habits, this patient is to go to toilet once every day. Now, does not go to toilet 1 day, 2 days. All right. And then anytime the person defecates, maybe the stool is very hard. So then you can then say, look, this is likely constipation. If someone has constipation, what advice will you give? Or how will you go about it? You have a client, and this client has not passed through the first day, the second day, the third day. What will you do? You are the caregiver, taking care of the elderly person. Okay. Okay. What else?
We shall report in nurse in charge.
Okay, report to the nurse in charge. You see, most times we don't have a nurse.
Yes.
Most of the two of our students that are working, taking
or
care of,
supervisor.
they don't have a supervisor. All right. Most of the nurses in charge don't have supervisor. The nurse assistants working currently, they don't have supervisor. They're just taking care of a client at home, and they may not have anybody to report to. So in that case, they are the ones to take decisions about some things, except when they take the client to hospital to see a doctor and to see nurses. All right. So you are the person in charge to give advice. Gifts, what will you do?
Yeah, we start with the patient taking a lot of fluids,
Okay.
and then we see if it doesn't work within like 12 hours. Then we forward it to my medical section.
Okay.
Is it?
Okay. Okay. Can I say something? Yes, the first thing is to be sure that the patient gets adequate food. All right. Second thing is what? To look at the person's diet. All right. If the person, the person has to take, you have to look at the diet and be sure that the patient gets diets that is rich in fiber, that's vegetable, fruits. You also have to look at the person's medication. So medication side effects, so medication causes constipation. Right, so if you look at the medication and be sure and see that, look, this medication, I don't think this medication causes constipation. Look at this other one. The other one doesn't cause constipation. If you see that this one causes constipation, what will you do? You have to withhold it. Not just withhold it, but you have to inform either the doctor or the nurses that, look, I think this is what's going on. All right. But the first thing to do is to increase the fluid intake, look at the diet, and ensure that the diet is rich in fiber. Okay. And then look at the medication before, and also get the doctor, let the doctor be aware of what's going on. All right. So then incontinence, what is incontinence? Incontinence is where someone cannot hold his feces and urine. All right. And it can either be that the person cannot hold only his feces, or the person cannot hold only his urine. And most times it can be that the person cannot hold both of them. And when the person cannot hold both of them, that is what? Double incontinence, right? The person cannot hold both urine, both feces. And for those that cannot hold urine and feces, most of them have to be on diaper, right? Or I think the name, even though nobody uses it, the right thing to call it is incontinence brief. Most times, the reason why they say incontinence brief is to avoid embarrassment. Because if you say that an adult is wearing diaper, the adults may feel embarrassed. And the right thing to say is that the person is on brief. But here, what is more of diaper? In patient records, they use diaper. But if you are talking with your colleague, if you use brief, that is a better way to express it to avoid embarrassment. All right. The toileting tools. What are the toileting tools that the patient can use? All right. The toileting tool the patient can use depends on the patient's problem. All right. So look at it, you have bedpan, you have fracture pan, you have bedside commode, you have urinal. The one you use depends on how strong the patient is. If the patient is mobile, the patient can ambulate. If the patient is bedridden, what we use is different. If the patient can ambulate, what we use is different. The patient can go to restroom, it's a different thing altogether. But looking at here, you have bedpan and fracture pan. What do you think is the difference between the two, or are they the same? Or they just looking at the design? I think they have different design. When do you use bedpan, or when do you use fracture pan? The bedpan and fracture pan, are they the same or are they different? How different? How different? They cannot lie in bed.
I think, sir,
Yes, 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 yes.
I think the bedpan is used for people who are healthy, like the legs are healthy, but they cannot move at the bed right there. And then this one looks as if somebody like this one, the fracture pan. I think it is used for people who are paralyzed, something like that, because of the structure, right? Yes, that is
The
my
people that are
idea.
paralyzed, okay.
Yeah, the people who cannot move the lower, because the shape you see it's sliding down. Yes, so you have to put it down, and then you put the ass in the middle there. Then they defecate or they urinate, something like that. But this one is a little bit higher, so I think the person can move. The body can move.
Okay.
Is it getting like is my explanation getting to you?
Yes, it got to me. Okay, Gibbs, what do you think? The inheritor will also. I think Gabriel has also said something. All right, so let's not waste time, okay? Looking at the two, bed pan is higher than fracture pan. See, the fracture pan is flat, while bed pan is high. So for patients that don't have problem around their waist.
Okay, on my side.
Yes.
On my side.
Yes, yes, yes. Yes, yes, yes. We can hear you. Okay, okay. We cannot hear you again. Okay, so for patients that don't have hip fracture, hip injury, patients that do not have surgery around the hip, who can raise their leg, right? For these ones, you can adjust them if you want to put bed pan. I think in level 5, we'll see how to put bed pan, how to put the patient, how to flex the hip when you want to put your bed pan. For some of them, for some of patients that are very strong enough, right? There are many things, such a patient can hold the bed and raise the hip for you to put your bed pan. And for some of them that cannot raise their hip, but there's no problem around here. You can flex this, all right, onto one side and put your bed pan. Why? Because there's no problem around here. But if a patient had hip fracture, let us know an elderly person that has osteoporosis, has hip injury here, or a person has surgery, all right? That person cannot do this. And you cannot also do much of flexing, all right? You need something that is flat. all right, that you can just put on the bed and slide it under. Okay, if you use something that is high, it will worsen the problem they have. That's why the physically made fracture pan. Bed is flat in such a way that it can slide under the buttock of a patient much easier than bed pan. Okay, that is the basic difference. Then what is this one? This is bedside commode. I think many of us have seen this. If somebody says it is mobile toilet, it has a bucket under here. It just look like wheelchair or like seat. Okay, this is for persons that can that can sit out of bed. All right, you can help them to sit out of bed. You use this. But for those that cannot sit out of bed, what do they do? You have to use bed pan or fracture pan. But those that are incontinent, you cannot use this. You cannot use this. What do? You have to use diaphragm. Then how about urinal? Who can use urinal? Female cannot use urinal. Are you sure? Sorry? This one. When a female wants to urinate, what will you give the person? A female in the hospital.
The bedpan.
Bedpan, right?
Because we cannot use this one. This one.
Okay. Okay. So when a man wants to urinate, which one will you give the person? This, right? All right. So this used by female both for urination or defecation. All right. Why this is used by men for what? Defecation. This is for urination by what? By men. So there are different designs. This one has a better design, but this one has cover or lid. Another thing again about it, that it has calibrations by the side. You can use to measure the amount of urine person made per time. And if you look at here, you see this CC. And then you look at this side, OZ, that helps you to measure the amount of urine. So let us know now you measure here, and you get 400 cc. And in the chart, what the chart has is mils. You measure here and you got 500 cc. How do you convert this into mils? Most charts use mils, ml. But this is in cc. If you check this as well, it is also in cc and OZ. So if you measure in cc, how do you convert it to mils? See, 1 cubic centimeter. This cc means what? Cubic centimeter. It is the same thing with milliliter. So 1 cc is equal to 1 milliliter. So if you measure here and get 500 cc, in your chart, the record of the milliliter, it is equivalent to 500 mils. I don't understand. ml is milliliter. cc is cubic centimeter. 1 cubic centimeter is equal to 1 milliliter. All right. So if you measure 500 cc, it's equivalent to 500 mils. Okay. All right. Then the next thing we'll look at here is catheter. I think in level 5, we'll see how to place this, how to remove it. All right. We'll also see how to place this one. How to. Then catheter. You can have a patient that is on catheter, right? I should be able to describe catheter, and there will be a session on how to pass catheter, how to remove catheter. Okay. I'm not sure if I answered your question completely, right? You asked 2 questions. Okay. What is the second one again? That refuse to drink. All right. So the first one, I hope I didn't confuse you, right? It is not easy, all right? Or it's not possible for a normal person, right, to take excess water. All right? As far as the person has intact hypothalamus, that is able to detect the osmolality of the person's blood or how dilute the person's blood is, it will not be very easy for the person to take excess water. Because as I take, even you, if you take a bottle of water now, as you start drinking, a point you reach when your test will be cut off. You cannot drink more than that until you become thirsty again. All right? So that is not possible. The only time someone can take excess water is if the person has psychogenic, just as I said, it's a more of a psychological problem that the person just feel like drinking water. And at that time, there are many things that could cause it. There's a problem with the hypothalamus that helps to regulate that. Or people that have head injury. But by the time someone has head injury, that head injury can also alter the hypothalamus, and the person may not be able to sense the osmolality in the person's blood. And the person can also have it's possible to take. And also another thing again is, for sometimes again in the hospital, if a person is giving excess drip, all right, that can also result in it's called I think osmotic demyelination syndrome and all that, which is much complex. Then for those that refuse to take water, okay, what is normally done is, first of all, you have to get the amount of water the person should get in a day, or calculate the amount of fluid that person should get in a day. If the person does not like to drink water, all right, you can supplement it by either the juice that the person takes, all right, or maybe soft drink or something liquid diet that the person likes, all right. Instead of giving the person water, if you know that, look, if you give this person this water, that she doesn't take water, you have to calculate the amount of fluid the person should get in a day and give more of it in the form that the person accepts, either in juice, they're making tea, or they're making something that you think the person accepts. And also, it's also, you may not have to force the person to take the water. You have to give the person just small at a time, but frequently. If you give him now and the person takes small and stops, fine. You have to come more frequently, all right, and present the same water to the person, all right, so that if you give it more frequently and the person takes little by little, the person will be able to finish the measured amount you want him to take per time in a day. But you have to limit the amount of water the person takes and supplement it or make it up with other drinks or other things the person takes that is in a liquid form. Is that clear? All right. All right, then coming to catheter, there are different types of catheters. And I think many of us have seen this, right? All right. Who has used this? Have you used it? I mean, in the hospital. Have you seen someone that is on it? In the urine bag? Yes. You have seen it on somebody, right? All right. Somebody that is on this. So this is catheter. There are different types. There is one way. One way has just one channel, just like this. This way. just one mouth, right? That is one way. This is two-way. There's another one that is three-way, three mouths. It is number of mouths that determines the type. You have one-way, two-way, three-way. That is the maximum. All right. Then when do they use one way? Those of if you have worked in labor room, that's where they use one way. For instance, when a woman is in labor and the woman's bladder is full, because of that full bladder, it will not allow the baby to come down. It will not allow the labor to progress very well. All right, because when the bladder is full, so this is the bladder. The bladder is here, and then this is the head of the baby. And this is the way. So if the bladder is full, it will block this place. It will be difficult for the head of the baby to pass through freely, and the labor can prolong the woman's labor. So what they do is, when they notice that the woman's bladder is full, they just pick the one-way catheter, pass it into the bladder, drain her urine, all right? And that can, okay, and the labor can just progress freely. So in that case, they don't need to keep it inside, okay? It's also used by people that have there's something called intermittent catheterization. Intermittent catheterization is for people that don't want to be on catheter. They need catheter. They don't want to be on it. All they do is that when they are pressed, they just put it in by themselves, drain their bladder, and remove it. When they are pressed, they put it in, drain their bladder, and remove it. The reason why they don't keep it inside is because if you look at this one that is two-way, this is the one they keep inside for a long time. This is why you can keep this one inside is because this one has balloon here. Look at this two-way, two mouths. This one is wide, this one is narrow. This wide one, so inside this tube, there are two channels here. You don't have to put it just like pen, all right? So inside here, it has so if you look at here, if you look at the tip of this catheter, you see it has two eyes or two openings. So urine enters here and comes out from these wide ports. Then this small one is connected to a small balloon that is here. If this catheter is new, you will not notice anything here. All right, but the reason why you can see something here is because you have used it over and over for demonstration. So look at this now. I think I need a different syringe. Sorry, I shall use a bit. This syringe is not the ideal syringe to use because it should be a syringe that is pointed. I don't know if you have seen the other syringe that have pointed mouths. That is the one that can fit into here. But this one has double mouth, so it cannot fit into this place very well. So because of that, I will improvise with this needle. So what happens is, first of all, they will pass the catheter, right? So when the catheter is inside, they will then push either sterile water and use the sterile water to inflate this balloon that is here. Or you can use air. So let me use air to inflate it. Let's see. Oops. Right, so first of all, they'll pass it. Let me remove it first. So they will pass it when it is inside the patient bladder. All right. They will then get this either with sterile water or with air, and then push the water in. Sorry. This is not the right thing to do. I think I need to get the right needle. So this will, okay. So it is inside. So the balloon is now inflated. So even if the patient pulls on it, it will be inside. Why? Because of this balloon. All right. I don't know why. I think this balloon has a problem already. Okay, this one doesn't deflate. So the patient can carry it around and can pull on it and all that. So if you have to remove this from a patient, what do? You cannot just go to a patient and pull it. Patient draw your attention and tell you, can you help me to remove this catheter from me? All right. You cannot just say, okay, I want to remove it and pull it. This has caused a serious problem. Someone may just want to remove it. If you do like this, it can cause injury the patient's urethra, and most times the patient can bleed to death. So the first thing to do is to deflate this balloon by removing either the water or the air. And you need to also know the amount of water that was used to inflate it. It may not be the person that did it, somebody else did it, but you should know the amount of water that was used to inflate it. Most times it is the catheter has two numbers that is usually written here. The size of the catheter, the amount of water that should be used to inflate the balloon. I think in level 5, I'll get a new one that has the two numbers. See how to identify and then how to pass and remove. Okay. Time is, so for three-way catheter has 3 mouths. It has an additional mouth to this. For one way doesn't have this balloon. It only has this channel just for urine to come out. So that's why they will just put it, drain the urine, remove. This one, the balloon, the person can carry it for many days. But most times, this one, not more than, I think, is a maximum of 3 weeks. Then you have another one called silicone catheter. That one is white. This one is yellow. The one that is yellow is Foley catheter. The one that is white, silicone. That's one the person can carry for 1 month and above. Then for 3-way has 3 mouths. What do they do with 3-way? The additional 3 mouths is if a patient is bleeding from his bladder. Let us say the patient urinates and the patient urinates blood, or a patient urinates pus, and they want to wash the person's bladder. What do? They cannot use this one. What they will do, they will use the 3-way. They pass the 3-way, and then they will connect drip to the third port or to the third channel. Drip, maybe sometimes they can put povidone or what other thing they want to add. It will enter, that drip will enter the bladder, wash the bladder, and then come out from here. Also, if someone has cancer of bladder and they want to give medication, sometimes they have to give medication directly into the bladder. All right. So what would they do? They have to use three-way. So they will connect the medication, and that will go directly into the bladder. And then there's a medication called Mesna, which you can give directly. Chemotherapy, you can go directly into it. All right. I think we'll stop here. Next week we'll look at okay. I think let me say this first. Lastly, so that we will not come back to this chapter again. There's another type of catheter called condom catheter that is usually used in elderly persons, which is here. If it's this one goes into the urethra. All right. So what the major problem that elderly people have is urinary tract infection. That is the commonest infection they usually have. All right. And in the hospital, the doctors may not want to pass catheter, because if they pass catheter, the risk of introducing infection to the urethra is very high. So what an alternative they may want to use for elderly person is this type of catheter that they will not enter the urethra. It just looks like condom that will just be around the penile shaft of the patient. It has a tip like this that will then connect to urine bag. So in that case, it will not have two mouths. It only has one mouth. This one is wide. All right. The wide one is what will enter the penile shaft. It has something you can use to secure it. All right. This other end is where you then connect your urine bag, and patient can be on it for some time. Then the last thing to say here again is perineal care. When you are cleaning a patient, especially female patients, you also have to be conscious of that. You clean from where to where? Front to back, and not from back to front, right? And if you are cleaning again, you start from where? Center to side. Don't move from side to center, all right? So that you will not carry infection from side to the center. And again, if a male patient is on catheter and you want to clean the patient, what do? This is the catheter, and this is the penile shaft. All right. Don't do like this. Let us say you want to clean this catheter. Let us say you have a gauze you want to clean. Don't clean from here to here. What do? You clean in two directions. Get your gauze, place it here, down. The same gauze, if you want to clean here, up. All right, in two opposite ways. If you do this, problem. If you come here, down here, also problem. Okay, we'll stop here. All right. Sorry, everybody. We didn't go on break. I myself, I'm so tired. So tired. Okay, please write your name in the chat box, those online. Okay. Then we have how many assignments now? Chapter what? Chapter 15, 16, 17. No, 16, 16. Sorry. Yes, 15 and 16. Yes, please. So 15 and 16. Do your assignments, submit. Okay. Have a great evening, everybody.
All right, good night, sir. Thank you.
Yeah, bye-bye. Yeah.
Thank you very much.
You're welcome. Bye-bye.